everyone, and welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk together about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm a mom of a preemie and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation. It's also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check out the CPBF website. I put it up on the screen there, canadianpreemies.org. There you will find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. Today's session is live, so please bring your voice to the table. Leave comments and questions in the chat, and we'll try to address them during our program today. It is through rich conversations like these that we can advance practice and learn together. So please participate and also let us know where you're watching from. Today's topic is one that families struggle with in NICU. And as a NICU mom myself, I don't think there's anything or many things worse than seeing your child in pain. Preterm infants in NICU experience at least 14 painful procedures per day on average. And that is a huge number. And then as understanding about premature infants' physiology improves, it's likely that more investigations and painful procedures may be added to the list of existing ones for the sickest babies in NICU. And so today we're going to be exploring whether there's a way to decrease the amount of painful procedures and experiences, and how families can help provide comfort to their infants and participate in decision-making with the clinical team. And to lead this important discussion, we have Dr. Namrata Todekar joining us. She's a clinical fellow in neonatal perinatal medicine at the BC Children's Hospital in Vancouver, where she takes part in the Small Baby Project. And that is a quality improvement project to improve care and outcome of preterm babies below 29 weeks of gestational age. And she's also a member of the nutrition committee there. Dr. Todekar is from India and completed medical school at one of the oldest medical schools in South India and received multiple gold medals and awards. She's also a blogger. She created a blog to help parents understand common neonatal issues, and she also blogs for CPBF sometimes, so you may recognize her name. Thank you for joining us today, Namrata.
Thank you for the introduction, Leah. I'm very excited to be part of Preemie Chats once again. And I think it's a great platform for families to connect with each other and also ask questions which they would otherwise hesitate to ask. But thank you for inviting me here.
Absolutely. I'll let you get to your presentation.
Okay. So welcome, everyone. Basically, I am trained in India and came to Canada for further specialization. So I'm in my third year of my fellowship, still learning amazing things every day. At BC Women's, we prioritize patient pain and comfort. And I took inspiration from the working group on pain and comfort in NICU to really dedicate myself to try and reduce painful experiences for both the family and the baby in NICU. So today's discussion is about pain, which is the necessary evil because we cannot avoid it altogether. But it is not a very good experience for families too. I do not have any conflicts of interest, and I'm not promoting any medication or a particular company or any particular procedure in this talk. We all know that with more and more modernization of healthcare, there have been many benefits to newborn health, especially. But at the same time, we are exposing very tiny babies to the experience of pain very early in life. And things that were not thought of a few decades before are now a reality where within first few hours of life you could see the tiny newborns having blood drawn, injections given, procedures performed, and families who are already in shock of having a sick preterm infant who seem to have lost their role of parenting in the form of not having um, access to breastfeeding, holding their baby, and going home, which they were all dreaming of during pregnancy. Along with that, when they see their baby in pain or experiencing uh, any sort of painful or stressful procedure, it adds to their stress. And it is important to speak about pain because if you have undergone things like antenatal, there would be mention about lung development, heart, the blood pressure, the brain, etc., etc. But I don't think any of you would have discussed about the topic of pain. Also, even in the first few days of life, the focus is mostly on how to make patients stable, how to overcome the acute issues, and in the long term also to discuss about feeding, etc., etc. But the pain and the stress is not spoken about a lot. And the research shows that neonates requiring intensive care admission, they encounter roughly 13 to 14 painful procedures. And the procedures may be classified as painful or not painful depending on the researcher itself. But the things that will pierce the skin were considered as painful. And this experience is happening during a critical period of neurodevelopment when the brain of this infant is very vulnerable to changes happening permanently. There was an article in the Boston Global newspaper in 2017 um, by Linda Rodriguez, and this article brought up the history of pain in babies, and it was labeled as when babies felt no pain. It was so interesting to look at the history that even until the end of the last century, although neonatal physiology was being explored and a lot of things like antenatal steroids and surfactant administration was being introduced into neonatology, people were not very sensitive about pain. When I say people, it is mostly the NICU physicians and the caregiving group. They thought that neonates were not capable of interpreting pain because they are unable to create memories, which is strange. And surgeries were performed, for example, circumcision would be performed without any pain or any anesthesia. It is really difficult to imagine that a baby would be given a paralytic agent so that he or she doesn't move during the surgery, but there was no analgesia given. So the amount of pain the baby would experience is tremendous, but even not being able to respond to that with bodily movements is really heartbreaking. Things started to improve after the 2000s, and a team of researchers from Oxford in 2015 compared the brain scans of infants and adults who received a painful stimulus. And 80% of the areas which responded to painful stimulus in adults also were active in infants, which proved that infants do perceive pain just like adults. And also the active regions were getting activated in the neonate with just 25% strong stimulus compared to that given to adults, which means that the response to less painful stimuli is as worse as a very painful stimuli. So this proves beyond doubt that neonates do experience pain, and then there was more and more research on that. The hypersensitivity or persistent pain issue, which is a long-standing adverse effect of being exposed to a number of painful procedures in early neonatal life, is all based on this theory, where the these 20 to 24 weeks of the time of the gestation is the time when pain pathways are being formed, and then they can perceive pain, but the response to pain or localization does not get much matured until babies get to term gestation. So they cannot really localize and discriminate the sensory input, and this leads to a surge in hormonal and physiologic responses to any type of painful stimuli compared to older patients, and that's how hypersensitivity and persistent pain results. And also, research has shown that early life pain has significant long-term effects on the neurosensory, the cognition, behavior, and other health outcomes in childhood and adulthood. In various surveys, adhesive removal and heel stick have been considered to be the most common painful procedures in NICU, amounting up to 20 to 30% of the painful experiences. So, when we look at prematurity alone, there are a huge number of babies who are born prematurely. And while a sick term baby, on an average, would spend around 5 days in NICU, the the preterm infants can stay in NICU for many months. The average stay is around 81 days, but with every day of prolonged NICU stay, the number of stressful procedures increases manyfold. So, in research performed in Brazil, the number of painful procedures increased or stressful procedures increased by 11 with every day of increased hospitalization, and painful skin piercing procedures increased by 2 to 3%. And also, the strategies employed to decrease pain also increased because there was more and more investigations or procedures being performed with a longer NICU stay, and the amount of medication used was much more than the non-medication part of treatment. So being born premature is not helping from the pain perspective, and if the stay is complicated and lengthy, it's again going to add to stress. So, therefore, the Canadian Pediatric Society and the American Academy of Pediatrics put up guidelines, which they update very regularly, that every facility treating newborns should have a routine assessment of neonatal pain. They should try to reduce the number of painful procedures, prevent and treat the acute pain, especially following surgery, and avoid prolonged or recurrent painful experiences in NICU. And various pain scores have been developed. In fact, one of the popular ones is the PIPP score, the premature infant pain profile. The NICU bedside nurse is the most common person performing the pain score, and different hospitals may employ various types of pain scoring system, and depending on the points accumulated for each particular variable, they would decide how uncomfortable the infant is. One of the examples in the PIP score is how the nurses uh, decide what is a painful experience and not is by looking at the facial expression. If the eyebrows are lower, drawn together, eyes are tightly closed, and the mouth is open, and the nose is broadened and bulging. But this, as you can see, if baby has got a breathing tube in, has got a feeding tube, or is under phototherapy having the eye goggles on, it is difficult to interpret. So there are a lot of shortcomings in the pain scoring system, and that's where family's role comes into the picture, where a bedside nurse would be visiting. Um, Intermittently, families can be constantly providing feedback to the treating team about comfort and pain. For example, if we look at heel stick, which is one of the most frequently performed invasive procedures to obtain either blood sample, just to check a sugar, or various other things. When the prick itself is painful, but the procedure to obtain a good blood sample, which is like the heel is squeezed, um, and then a number of samples are collected, the squeezing part is also very painful. And during that time, if a pain score is performed, then it depends on so many different things. So mainly um, it is subjective. So one particular person may say that this brow furrowing is a point one, and some other care provider would say that no, this is zero. So zero, one, two is how they score, and also parameters like the heart rate variability or um, the change in vital signs might not be only dependent on pain, might also be dependent on the various other issues going on. Some pain scores also require laboratory markers, which are not very useful. And if a baby has been sedated or given any paralytic agent, then these pain scores might not be useful at all. Therefore, when it comes to interpreting pain, it, I think it should be assumed that they are always uncomfortable, and maintaining status quo or avoiding disruptions in their day to day sleep wake cycle would be the best approach. So when it comes to pain management as such, there are non-medical methods and medical methods. Non-medical methods is the core of our discussion today, where families and care providers both as a team can work together and try to reduce the discomfort and pain. So the most important part is clustered care. Clustered care, it means by discussing amongst each other, you can time the bedside interventions like a diaper change, a suctioning of the mouth and the ET tube, and that daily physical exam can be clubbed together in one interaction with the baby, and that will require that the bedside nurse has to inform the doctor and say that I'm going in at this time. Maybe you can do your physical exam at maybe 10 a.m. So that is teamwork. And also anticipating laboratory testing. It has more to do with the clinical team as such. If someone is thinking about doing a glucose check, and also there is a 24-hour blood work coming up at a different time, they can discuss and club all of them together at a time which is convenient instead of having two separate books. And also the use of handheld devices which can perform multiple analysis from a single blood sample is also very helpful in reducing the number of painful procedures. So the blood gas machine, which is handheld device, can give a number of results. The glucose checking machine is also a handheld device and can give us a real-time result. And in case there is 3 to 4 heel sticks required per day, the treating team can consider a peripheral arterial catheter, and in bigger infants, they can also consider a venous catheter for daily blood sampling. So this is an example of small baby care, which I was part of at BC Women's NICU, and a close up. I'll be showing a close up where the Q based care is employed for clustered care administration. So there is something called as go slow no technique. Go is like the green signal. Baby is ready for an intervention, be it painful, stressful, or non painful. Slow is a phase where baby would be showing some signs saying that please slow down, um, and I may or may not go to the go phase again. I might go to the no phase. And no is just leave me alone. So as you can see, go phases that the baby is awake, the vital signs are uh, normal, and baby might be putting hands in his or her mouth, wiggling and waking up, quite alert, maybe pink with having regular breathing, and maybe trying to grab onto something, like grabbing onto the wires or maybe the tube or maybe a finger. And the score which we use in our hospital is the BIP score, and the score is 0 to 2. So this means you can talk to baby, touch, care for the baby, and this is the ideal time to handle. The slow phase is where baby might be crying or fussy. There may be this furrowing, grimacing, maybe gagging, hiccups, yawning, sneezing. There might be change in the color of the body, breathing irregularly, or there is jitteriness, or baby might be trying to fall asleep. The fist is like splayed sometimes, and showing not really opening eyes, and maybe a little bit limp or arching the back, and the pain score is higher. So here it is time to give us like a pause to whatever is going on and see if baby needs more support, or is it okay to continue the care. But on the other hand, stop means baby might be inconsolable, might stop breathing, heart rate might drop, or heart rate might shoot up, or the oxygen saturation might decrease, and there might be need for more help. So that is the sign to stop whatever you are doing, call for additional help, and do not make me more uncomfortable. This is a strategy employed in the small baby care to reduce pain. And also on the door, we display the small baby care, um, um, like a pre handling checklist where anyone entering into the room first has to discuss with the nurse whether it's the right time or not. And then, once inside the room, use soft voices, minimize the number of people in the room, reduce noise. If we have a pager or a intercom, then just put it on do not disturb mode. Keep baby comfortable and contained. Do not keep any object on the incubator. And when the incubator cover is on, then there can be suitable lighting. But once the incubator cover is off, then minimize the lighting or use a protective eye covering. So not only focusing on pain, but also on comfort, so that the overall experience is less stressful for the tiny baby. But when it comes to actually treating, actually reducing pain, I would say that the treating team uh, can do multiple things, and treating team includes the family-centered care. In NICU is the core of modern neonatology, and treating team always includes any family member, either it's mom or dad or even grandparents, who are there with the baby and have been observing the infant. So basically, they can plan and try to reposition, which is nothing but positioning the neonate appropriate for their maturation. So supporting the limbs and also the trunk, trying to have their limbs in the midline, flex the hips and the knee and the elbow. And the other intervention could be swaddling, just wrapping in a cloth or blanket with their arms tucked in, and which will make them feel secure. Trying to duplicate the position in which they would usually be while they are in mom's womb. decreasing environmental senses like the noise and the light. And nesting is like having a boundary. It's like a fake uterus, trying to imitate that environment. And facilitated tucking is that the limbs are in close proximity to the trunk. And containment holding, where, as you see in the second picture, the caregiver can use their hands to hold the baby and make them feel secure. Tactile soothing is nothing but gentle touch or bum taps. And if you are all by yourself, families, depending on how the baby's condition is. If, for example, your baby is now transitioning from tube feeds to breastfeed, then you can do something called as non-nutritive sucking, where use of a dummy or a pumped breast can be used to help settle the baby down. And if breastfeeding has been started, you can do breastfeeding while a painful procedure is being performed, allowing neonate to grasp your finger in those early days. Skin to skin care, talking to your baby, massage therapy, and hand hugging are all the different other methods which can be employed. Um, so it's important for families to discuss with the treating team if they can perform these things. Most of the time, it is allowed, and everyone will be happy to for you to take part actively in reducing pain. I think only in situations where, if there are multiple lines, invasive lines, and that there is a risk of it coming off um, during the skin to skin care, maybe only that time someone would say that probably not the probably let's not do the skin to skin care today. But there is no contraindication for gentle tapping, talking, hand hugging, and also non-nutritive sucking, or introducing few milliliters of breast milk while a painful procedure is being performed. The medical methods are plenty, and I'm just mentioning the most commonly used medications: morphine, fentanyl, and midazolam. But beyond that, there are many other medications too, and they come into play when the non-medical methods uh, are not helpful in settling baby down. Also, if a baby is having issues with synchronizing with the ventilator, then uh, the uh, the treating team tends to use these medications, and it is not free of adverse effects or disadvantages. So there could be situations where the treating team might underestimate pain. One could be because of the potential adverse effects of the painkiller medications, or they would not be able to interpret pain due to the limitations of the pain scoring system. And that is one of the reasons where the painful experiences in NICU shoots up significantly. And in a survey which was administered to both doctors and nurses, nurses perceived pain much more frequently than doctors. So they they are much better in assessing and interpreting preterm infants' responses as painful, stressful, or not than the physicians. Chest tube placements and lumbar puncture were considered most painful by many nurses, and I think it is better to rely on the bedside nurse's opinion when the physician is in doubt. Also, they in this is just to mention that a collaboration and discussion among all healthcare providers and the patient families is very helpful. There can be barriers like hierarchical relationship, it's just the out of fear or respect, families would just hesitate to discuss about this thing, while they would be hearing many things like, oh, the heart is having this problem, we are going to treat it in this way. So you would feel that, oh, when they are discussing so many important things, why should I bring this issue of pain? I would They would think I'm stupid or something like that. But I think that is a big barrier, which everyone needs to break, and also that a lot of work needs to be done in getting pain into the conversation very frequently. Other situations, just to mention, is pain from surgery, from eye exam, and also in intubation. From surgery, definitely there is need for medical treatment, non-medical treatment, or the non-medical things like hand hugging might not be enough to reduce the pain from any type of surgery. And frequent assessment and feedback from the family also will play a role in minimizing the duration for which that particular pain medication is being used. And now it has been proven that a simple medication like Tylenol can actually help in reducing pain than the opioids, um, than the need for long-term opioid treatment. Of course, 1 or 2 days after any type of surgery, opioids might be useful, but then our good old friend Tylenol is probably more than sufficient. When it comes to intubation, ventilation is, I think, one of the most common causes for prolonged pain medication administration in NICU. And with more and more younger babies surviving, they tend to have prolonged exposure to this medication. And the answer to which is the best medication, or what is the best time to stop, is not clear. There is no ideal method for pain relief in assisted mechanical ventilation, and it is a combination of both medical and non-medical interventions. And for retinopathy of prematurity, if it is a surgery, then there is no doubt it has to be performed under anesthesia, and then there is need for pain relief. But during eye exam, it is very unfortunate that people tend to underestimate the discomfort caused by these eye exams, and use of local anesthetic is recommended, and people are now starting to use it. Unfortunately, even advanced centers all across the world are not uniformly using these local anesthetic drops before the eye exam, but things like oral sucrose and other non-medical pain management techniques have been used. So overall, I just want to say that partnering with families, optimizing the protection of skin, their nutrition, safeguarding sleep, position and handling, will create a healing environment. And as a team, of as a team, like a member of the medical team, the families can advocate for their infants in the NICU, make their pain matter, make their pain understood, make their pain visible, and make their pain better. As you can see, the treating team will have a wide um, variety of physicians and uh, people from all different specialties, and they might be in different stages of their life. And I would say that until you yourself have experienced that type of pain, you might not be really sensitive to what that particular baby or family is going through. So no, it doesn't matter if someone is not responding to your request of discussion with pain. You can bring it up again and again, because I think that the more you educate, the better it is for a stress-free experience. So again, just to summarize, it is the non-medical methods which significantly reduce need for analgesic use in NICU. Parents' active involvement is a critical first step, and many medications might not be totally unavoidable, but coming off medication is possible. and talk to your treating team about it every day, every time, and you can try and help reduce painful NICU experience. I'm proud to say that BC Women's NICU is a Child Kind certified hospital, and Child Kind certification means that we make pain and comfort a priority by having a policy for pain relief, policy to provide comfort, and actively involve families in decision making. Um, I'm really thankful for Leah for sharing the resources for families. I think you can find them somewhere here in the chat, and I'm really happy to take any questions if you have.
Thank you so much for sharing that with us. It,
Okay.
as we said before you started today, it's a topic that is every family cares about because of the amount of painful procedures there are in NICU. And I just want to pop up a comment we had during your presentation from Sarah. And to me, it just demonstrates, how it's not just a temporary thing that families go through in NICU, but it can be a long standing, uh, ongoing issue. Sarah shared that she had to work for a year desensitizing her 24-weeker's feet just to be able to put her feet on the floor to start to weight bear, and had to work for a long time with being able to wear hats and glasses.
Yeah, I think it's the heel pricks which probably made the feet such um, hypersensitive to any sort of stimulus. This is just one of those examples. And in the NICU, we rarely look at infants who come in follow up, and these stories do not come up, and the treating team is more focused on acute issues.
Right.
Yeah, and ordering investigations and trying to get things settled before their shift is done.
Hmm.
And I think it will take a lot of effort from both the hospital administration and also the physicians as such to club all the investigations together. And we are, I think, going in the right direction. I think from at least since the realization that infants do perceive pain,
Hmm.
and their long-term effects have been revealed through research. People are trying to club together investigations, and there is a lot of work which is being done.
You mentioned the pain scoring that differs from unit to unit across, well, probably the world. But do you think, at least here in Canada, like, should we have standardized pain scores?
Um, I think the Canadian Pediatric Society recommends having a pain assessment system, but does not recommend which one. A few pain assessment systems require real-time monitor being attached to the body, like the heart rate, respiratory rate should also be scored, and some really good ones they have a laboratory investigation with them, which is really strange. It is in such a way that if the 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 interpretation of that particular score is very close to the real experience, but it is so complicated that no one can use it. So I think BIP score, the BIPP score, is
Hmm.
the one which has got a lot of acceptance because it is based only on clinical parameters, and many centers do use it, and none of them is perfect. So it's a combination of both clinical judgment and also as like the perceived discomfort from the family's perspective, and also change in vital signs, everything. So the answer is yeah, there is none.
Yeah, but we maybe could use that down the road.
Maybe.
I thought it was interesting that you said that 1980 is when the medical community started acknowledging that babies experience pain, because that really wasn't that long ago.
Yeah.
And I'm just wondering, now that we know this, why aren't, in your opinion, why aren't measures always taken to decrease pain? Because we do know, even when you said like sticker removal, like, do you think it's the perception that it's not that bad and that's why um, measures aren't offered or happening in the moment? Or why isn't it always the case that there's things put into place to reduce pain for our babies?
I think it's the population that we are speaking about. Babies do not speak. They cannot.
Mhm,
They cannot say that this is painful and this is not.
mhm.
And babies' only way of communication is crying. The old school principle is a crying baby is a healthy baby. So
Right.
so uh, if baby is moving about, people would say that okay, this is a very active baby, and wouldn't think about pain as their first cause of cry. And also, not only uh, not only that, there are so many pressing demands in NICU. Um, it is quite stressful for a nurse to even have two patient assignment, because the demands of the other baby might be uh, or pressing her or causing stress on her,
Mhm,
and she would be probably planning her next few hours. She would say, okay, I will do a diaper change, and I will do this for my baby number one, and then the baby number two is going to have a ROP exam, and I have to prepare, blah, blah, blah. So I think it is a combination
mhm,
of the stressful NICU environment, and also the fact that babies do probably um, they do not respond the way that people would assume they would with the painful experience. They might just stop breathing in one case, and in other case they might just show a change in their color. It would
mhm,
not always be a verbal response.
mhm. I'm gonna let you go here in a minute, but just wanted to clarify on your. It was really interesting to hear about your go slow stop method that you've been using, and just wondering, clarification. Do you do that assessment multiple times during the procedure? Do you do it at the beginning and then not again, or is it something that happens mid procedure? So for example, you were saying if baby is fussy, then you slow down and kind of interpret what's happening. Would that be before you even start, or at what point would people use that method?
The go slow stop method is always done at the beginning of their interaction with baby. Before entering the room, the things are discussed that okay, this handle we are going to do A, B, C, D, and
Mhm,
once the incubator door is open, they would see for the signs, gently touch if baby is in the go or slow phase, and then depending
mhm.
on the response, they would proceed.
Okay, very interesting. Well, as you said, this is an ongoing kind of whole world of pain because it has not been that long since we've even started addressing pain in NICU. So I appreciate you sharing your knowledge with us today and your presentation. And so thank you for joining us, and I hope you have a great weekend.
Thank you very much. It was glad to be here, and I really appreciate all the questions you asked.
And thank you for joining us online here today for Preemie Chats. A special thank you to our sponsor, AstraZeneca, for their ongoing support of this educational program. And just a reminder that if you missed today's session, then you can head over to canadianpreemies.org. I popped the website up there again, and you can see this whole session and past editions of Preemie Chats. You'll also find many resources and support options available there. And you'll be reminded that CPBF is a charitable organization and it depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I do hope you're able to join us next Friday at 1 p.m. Eastern Standard Time for a Father's Day special. This is your reminder, Father's Day is coming up on Sunday, June 18th. So next Friday, we will kick off your weekend speaking with some NICU dads and NICU dad supporters. Don't miss it, and I hope you all have a great weekend. Thanks again for joining us.